Hi, it's Professor Erica Jones, and I'm here to talk to you today about cerebrovascular accident, also known as CVA, also known as stroke. The learning objectives for this lecture are for you to be able to describe the incidence of and the risk factors for stroke, or CVA, to explain the mechanisms that affect cerebral blood flow, to compare and contrast ischemic and hemorrhagic strokes, to correlate what these different strokes look like, the left-sided versus the right-sided stroke, and to talk about diagnostic studies that are performed for people who are having a stroke. We're going to talk about the collaborative care, drug therapy, and nutritional therapy for patients who've had a CVA. We're going to talk about acute and subacute nursing management of the stroke patient. And we're also going to talk about the psychosocial impact that a stroke has on the patient and their family. So, talking about stroke, cerebrovascular accident, and you'll notice I use the two terms independently. Most often I'm going to say stroke just because that's what I'm used to and what I'm familiar with. They're interchangeable. There's no difference in the meaning. And you might also hear the term brain attack used. There's two different kinds. Both kinds involve ischemia to the brain. There's an ischemic stroke, which refers to a blood clot or a thrombus that lodges in one of the blood vessels. This is the more common cause of stroke, and it can be caused by many different things. Most often, people who have atrial fibrillation and irregular heartbeat can have clot build in the atria of the heart and then flick up to the brain. That's a common cause of an ischemic stroke. Patients with cancer or a hypercoagulable state can also have clots occur, and sometimes it will be an embolic event where a blood clot will form somewhere else in the body and then be flicked to the brain and lodge in a blood vessel there. Hemorrhagic strokes, otherwise known as bleeds, occur much less frequently than ischemic strokes. It only accounts for 13% of strokes. These include ruptured cerebral aneurysms, which we're going to talk about in an entirely different lecture. A hemorrhagic stroke can also be caused by hypertension or due to a brain tumor. So how often does stroke happen? I'm sure that if we were in the lecture hall and I asked you to raise your hand if you knew someone or if there was someone in your family that had a stroke, a good percentage of you would be able to say that you've had experience with a stroke personally. The severity of the loss of function after a stroke varies pretty widely according to the location and the extent of the brain damage. Also, there's a definite physical, cognitive, and emotional impact on the patient and also on their family as well, because this is typically something that happens quickly and without warning, and people do have a very hard time coping with a stroke after it occurs. About 1 out of every 20 deaths in America is due to a stroke, and on average, 1 American dies from stroke every 4 minutes. And more than 795,000 people per year in the U.S. have a stroke. It's the 5th leading cause of death in the U.S., and it is the #1 cause of serious long-term disability. 15 to 30% of those that survive a stroke will live with a permanent disability. 26%, that's over a quarter, will require long-term care 3 months after their stroke, and it is a lifelong change for the survivor and their family. There are many disparities in stroke, and many of them are related to African Americans who have a higher incidence of strokes than whites. The rate of first strokes in African Americans is almost twice that of white people. African Americans have an increased incidence of hypertension, diabetes, and sickle cell anemia, which are all risk factors for stroke. And if you look at a map of the United States, there's actually what's called a stroke belt. You can Google it. It's the southeastern states where they have higher rates of tobacco use, higher rates of obesity, and these are also modifiable stroke risk factors. It's more common for men than women to have a stroke. men are more likely to have an embolic stroke, where women are more likely to have a hemorrhagic stroke. And women also have lower survival rates than men do for stroke. There are also disparities in stroke treatment, where women are less likely to receive TPA acutely if they've had a stroke. And it's important to note that oral contraceptives and pregnancy can contribute to stroke risk in women. So there are different modifiable and non-modifiable risk factors. The non-modifiable risk factors are obviously things that the patient can't change. Age, people after age 55 are higher at risk to have a stroke. Stroke is more common in men, but more women actually die due to their strokes. There's a higher incidence in African Americans than in whites, and nobody can change their ethnicity. Heredity and family history can play a role in stroke risk, and those are also non-modifiable risk factors. And hypercoagulability and atrial fibrillation are both considered not modifiable risk factors, but they can be treated with anticoagulation and close monitoring, and we'll talk about that a little bit later. So some of the modifiable risk factors for stroke include hypertension, heart disease, cholesterol, smoking, obesity, sleep apnea, metabolic syndrome, lack of physical exercise, poor diet, especially one high in saturated fats, and drug and alcohol abuse. And specifically, cocaine is one of the biggest risk factors when it comes to hemorrhagic stroke due to high blood pressure, because it's going to raise your blood pressure. Stroke is something that is very time sensitive, and we use this acronym FAST to remind people that time is brain when getting treatment for a stroke. So if you use this acronym FAST, the F stands for face. Does the person have a facial droop? Can they smile? Is the smile even? Arm. If you ask the person to hold their arms up like they're holding a pizza with their palms up, have them close their eyes. If one of those arms drifts downward, then we consider that a drift, and it's a sign they need treatment for their stroke. If they have difficulty speaking or their speech is slurred or unclear, that's another sign that they're having a stroke. And time is in the acronym because it's incredibly important for patients who are having a stroke to get treatment right away. The quicker a person gets medical attention, the better they can recover from their stroke. And some treatments are time sensitive, and you might be outside of the window for treatment. If your patient is in the hospital setting and you're concerned that they're having a stroke, know your hospital's facility. If your patient has new neurodeficits or any change in their exam. This is a picture from Bay State Medical Center. It's their acute stroke protocol. They include the two items balance and eyes, because cerebellar strokes can cause difficulties in this area without having the typical droop or drift of a stroke in another area of the brain. And the plan is call rapid response team at Bay State Medical Center. If you're in a long-term care facility, you call 911. And remember, again, time is brain. Stroke affects the cerebral circulation, and I just want to have this little slide about cerebral blood flow so that you can understand what's happening when a person's having a stroke. Your cerebral circulation consists of two major pairs of arteries, the internal carotids, which go up the front of your neck, and the vertebral arteries, which go up the back of your neck. The major branches of the carotids in the front are the MCAs and the ACAs. So you have the middle cerebral arteries and the anterior cerebral arteries. And those vertebrals in the back connect to form the basilar artery, which then separates into the PCAs, the posterior cerebral arteries, which then connect to the anterior cerebral arteries. So you have this circle that is called the circle of Willis, which connects the anterior and the posterior cerebral circulation. Now, why is this important? It's important because your brain is kind of like a greedy child. It needs a lot of blood flow. It needs a lot of oxygen in order to function correctly. We are talking like a 3 to 5 minute window for cerebral hypoxia before permanent damage occurs. So this circle of Willis is really like an insurance policy that if one of those branches of the cerebral blood flow is blocked, sometimes like a PCA can backfill an area which is blocked and allow patients to have blood flow even if one area of their cerebral circulation is blocked. So it kind of works like an insurance policy to help perfuse the brain. As mentioned in the previous slide, the brain requires a continuous supply of blood to provide oxygen and glucose to the neurons. It requires about 20% of your total cardiac output, and cellular death will happen in about 5 minutes if your cerebral blood flow is blocked. That's why time is so important when treating stroke. Cerebral autoregulation is a mechanism that your brain uses to make sure that it gets enough blood despite what's going on with your blood pressure. In stroke, this mechanism can be impaired. This is why sometimes you'll see patients have very high blood pressures when they have a blockage in their brain. The brain is asking for more blood flow despite this blockage, and your body responds by pushing your blood pressure up. Your systemic blood pressure, your cardiac output, and even the viscosity or the thickness of the blood all affect the blood flow to the brain. Patients who have long-standing atherosclerotic disease in their cerebral circulation might develop collateral circulation, which can prevent severe injury and a stroke. And this occurs most often in elderly patients with existing disease. So sometimes an elderly person might do much better than a younger person with a stroke just because they've had somewhat blockages in their brain and they've developed this collateral circulation, new blood flow to kind of prevent an injury from occurring. Young people are much less likely to have collateral circulation and often do poorly when they have a stroke versus an elderly person. And as we talked about in the previous slide, the circle of Willis, that connecting cerebral circulation acts like an insurance policy to prevent massive brain damage in an ischemic event, which can affect one of the major cerebral arteries. So you may have heard the term mini stroke. What is a TIA, a transient ischemic attack, sometimes referred to as a mini stroke? The most important thing about a TIA is that it's temporary. This is a temporary focal loss of function. It's caused by a lack of blood flow to an area in the brain, and it lasts less than 2 hours. Most of them resolve in 3 hours or less. They are a warning sign of cerebrovascular disease in the brain. They present often the same way as a stroke, with weakness on one side, hemiparesis, numbness, or aphasia, difficulty speaking. Patients can also have amaurosis fugax. Please remember this term, you will need to know it. Amaurosis fugax is a temporary loss of vision in one eye. It has been described as a veil or a curtain being pulled over one or both eyes. Patients can have multiple symptoms, which can involve movement, vision, loss of hearing, or tinnitus if it is an area in the back of the head, the vertebrobasilar system, that's affected. The most important takeaway from this slide is that a TIA must be worked up just like a stroke. These patients need imaging, they need cardiac monitoring, and they may need an antiplatelet or anticoagulation for treatment. It can be a result of carotid artery atherosclerosis, and we're going to talk about that a little bit later. This is a nice visual of the 3 major types of stroke. These first 2 types in A and B are both ischemic strokes. They're both blockages. The first one is a thrombotic stroke, which means that a clot forms in an area already narrowed by atherosclerosis. So you can see that plaque buildup has narrowed the artery and a clot has formed in the middle, effectively blocking blood flow. The second picture, picture B, is an embolic stroke, which means this clot has detached from another area. So this might be your patient who has atrial fibrillation, who had a large clot buildup in the atria of the heart, and then it subsequently was sent up to the cerebral circulation, blocking the blood flow in an area of the brain. Typically, I use the mnemonic emergency. Embolic equals emergency. They both start with E because in an embolic stroke, you might have more rapid onset and more severe deficits. In photo C here, you get a picture of a hemorrhagic stroke. This area at the bifurcation of two blood vessels has burst. This may be due to a cerebral aneurysm. We don't know. It may be due to hypertension. But anyway, this blood is leaking out of the vessel and you're not getting the blood flow that you need after that area of leakage. The blood itself also can damage your brain tissue, and it's not going to stop until you clot and kind of stop that area of leakage. First, we're going to talk about ischemic stroke. So ischemic stroke results from a blood vessel in the brain being blocked by blood clot or thrombus. 80% of all strokes are ischemic. The symptoms include confusion, facial droop, motor deficits, or weakness, numbness, and any number of cranial nerve deficits or sensory deficits. The brain is a big organ, right? And it connects to everything that we do. So a large stroke, you're going to see those face symptoms, right, are fast symptoms. You're going to see facial droop, you might see arm drift, you might see speech problems, and you know you need to get treatment quickly. Treatment includes treatment that we have called TPA, which is tissue plasminogen activated, tissue plasminogen activator. It's basically a big clot buster drug. It can be given to break up the clot, and there are also endovascular techniques that can be used where trained technicians can go in and actually retrieve a clot from the cerebral circulation. As we talked about previously, there are two different kinds of ischemic stroke. There's a thrombotic stroke, which occurs from injury to a blood vessel wall and formation of a blood clot. This is the picture of the atherosclerosis with a blood clot kind of blocking it in the middle. This is the most common cause of all strokes. About 60% of strokes are thrombotic stroke. Clot forms in place. Embolic stroke occurs from an embolus lodging in and occluding a cerebral artery, resulting in infarction of the resulted area. Majority of these originate in the heart because of atrial fibrillation, and this is your second most common cause of CVA. Embolic strokes can also result from air or fat embolus, much more rare, like in the case of an injury or a broken bone. And an embolic stroke, remember E stands for emergency, usually it results in a rapid onset of severe symptoms. Diagnosis of stroke and treatment guidance is determined by a plain head CT, just a plain head CT, no contrast. Some ischemic strokes, depending on the size of the clot and the location, can be seen on a plain CT, and always you're going to be able to exclude a hemorrhagic stroke or a bleed because blood on a head CT shows up bright white. So your patient's going to get a plain head CT. If there's no bleeding seen, then you're going to be able to determine treatment, and they might be eligible to have TPA given. The goal of TPA is to dissolve that clot and hopefully restore brain function. In addition, if there are no signs of early brain death on the CT, the patient might be a candidate for clot retrieval using endovascular techniques, and a vessel study such as a CT angiogram or CT angio can be done in the brain, which will show you the blood vessels, and it can show you if there's a large vessel occlusion that your patient might be able to get treatment for. MRI is done to evaluate the damaged areas of the brain in stroke. This is typically done after the plain head CT and after the patient has received any treatment, and it can be used by the neurology team to guide prognosis. The other type of stroke that your patient may have is called a hemorrhagic stroke. This picture shows two different kinds of hemorrhagic stroke. Subarachnoid hemorrhage, which happens under the arachnoid matter of the brain, and an intracerebral hemorrhage, which is kind of like a bruising area inside the brain tissue itself. Subarachnoid hemorrhage occurs as a result of a ruptured aneurysm most often, and that's going to be discussed in a different lecture. It's going to be talked about in the vascular malformation lecture at the end of the semester. So a hemorrhagic stroke results from bleeding into the brain tissue itself. It can be intracerebral inside the brain matter or intraparenchymal inside the brain tissue. It can also occur in the subarachnoid space or into the ventricles themselves. And it is a bleeding within a brain, intracerebral hemorrhage caused by rupture of a vessel. Usually there's a sudden onset of symptoms, most often headache. They can progress over minutes to hours because of ongoing bleeding, and the prognosis, unfortunately, for a hemorrhagic stroke is poor, with a 30-day mortality rate of 40 to 80%. Intracerebral hemorrhage is most often caused by hypertension. It can occur during activity. It can be a sudden onset with progression over minutes to hours, and the extent of symptoms varies and depends on the amount of blood, the location, and the duration of bleeding. Common manifestations include neurologic deficits, including loss of consciousness. Patient most often will complain of a headache. They can have nausea and or vomiting, and also these patients can be very hypertensive. So here's our stroke case study. Mr. PD is a 73-year-old man who was admitted to the hospital with right-sided paresis and expressive aphasia. He went to bed normal and was found by his family 8 hours later with these deficits. He had been experiencing periods of confusion, right-sided weakness, and slurred speech for the past several weeks. So these episodes were brief and resolved completely within an hour, and no treatment was sought. So what were these episodes? So your patient has right-sided weakness and cannot speak. And even though it's brief, what would you say has occurred? Patient, because the deficits resolved completely, it would be considered a TIA. The symptoms are the same as a stroke, and it's very important to make sure that patients having these deficits, even if they resolve completely, get worked up. You want to make sure if you see patients who've had a TIA or a mini stroke in the past, get worked up, go to the hospital, tell them what happened, get a CAT scan done, have an echo done. You want to know why these occurred. Even brief and completely resolved, these episodes still need to be worked up just like a completed stroke. Mr. PD has a history of COPD. He has had a heart attack 15 years ago, and he has known atrial fibrillation. He takes Coumadin, warfarin, but he misses doses occasionally. His INR was 1.4. So for patients who have atrial fibrillation and are on an anticoagulant like Coumadin, their INR should be therapeutic between 2 and 3. It's very important that you educate your patients on regularly taking their anticoagulation and making sure that they follow up, usually with the Coumadin clinic, and have their labs drawn regularly to make sure that they're on the correct dose and that it is effective. Mr. PD gets admitted. Over the first 24 hours, his neurologic deficits gradually progressed. By day 2, he has right-sided paresthesias, hemiparesis, and global aphasia, what is probably the cause of his stroke. So, patient has atrial fibrillation. They are on anticoagulation, but don't take it regularly, and they were subtherapeutic with their INR. So it's highly likely that a clot formed in the right atria because of his atrial fib, and he suffered an embolic stroke as a result. The symptoms that you're seeing right-sided paresthesias, right-sided hemiparesis, and global aphasia probably means he has a left-sided stroke. So for your studying, if you don't know what these words mean, paresthesias, hemiparesis, and aphasia, you want to make sure that you learn your stroke vocabulary because that's going to be on your exam. So when looking at risk factors, he had some, let's see, modifiable factors, heart disease. We don't know that he was a smoker. We don't know that he had hypertension. We can't modify his age or his gender. And atrial fibrillation is not a modifiable factor because you can't change the atrial fib, but the treatment is something that you do have control over. So for Mr. PD, of course, you're going to be sensitive to the family and sensitive to your patient, and you're not going to say things like, well, you should have been taking your Coumadin and going to the Coumadin clinic. But as far as education as to why this stroke happened, it's highly likely that he had an embolic event because he was not therapeutic on his Coumadin and he had atrial fibrillation. So could it have been prevented? It's possible. But sometimes, people are therapeutic on their Coumadin and they still have a stroke or they have a bleed. So you never want to, make your patient feel bad by saying, certainly this could have been prevented, but for teaching purposes, you want to make sure that you educate your patients with atrial fib how important it is for them to be anticoagulated and to be regular with their medication and their follow-up appointments at the Coumadin clinic. So his manifestations are definitely related to the location of a stroke. The tissue destruction in the brain is the basis for neurologic deficits that happen. And because the brain is, in control of so many of your body functions, it affects many body functions. The stroke symptoms are related to the artery involved and the area or hemisphere of the brain that it supplies. And you want to remember with stroke, the time of the onset of symptoms and the length of period of ischemia is very important. So the location and size of the injury in stroke determines the symptoms. Typically, you're going to see stroke symptoms peak in severity over the 72 hours from the insult as a result of cerebral edema. So the brain is injured and then it swells. As the swelling decreases over the next several weeks, symptoms may decrease. And this is a nice picture that just shows you different functional areas of the brain. The frontal area controls emotions and higher intellect and self-control and inhibition. Your eye movement is across the top. Your motor strip is kind of at the side of the top and the back of the top. And your speech development is on the back, kind of right, and most often the left side is where patients are going to have the more severe speech deficits in a left-sided stroke. In the back of the brain, you're talking about, vision, and the cerebellum, the kind of brown area here, is associated with equilibrium and muscle coordination. And just a quick blurb on cerebellar strokes. Sometimes with cerebellar strokes, the only problem the patient will have is dizziness and gait instability. So it's important if your patient is all of a sudden dizzy and can't move around like they used to, they could be having a cerebellar infarct. But they won't have any other like motor signs or speech signs or vision signs. It could all be just gait stability and muscle coordination. What do a right and a left-sided stroke look like? So patients who have a stroke on the right side of the brain will be paretic on the left side. They might have neglect of the left side. You'll have to go to their right side to speak with them. They may look towards the side of the injury, so they might have a right-sided gaze. They tend to deny, or minimize any problems that they're having because of the stroke. They may have rapid performance and short attention span and be very impulsive. These patients are more likely to have safety problems and impaired judgment, and they have impaired conception of time. Patients who have a stroke on the left side of the brain will more often have difficulty with speech and language. They can have aphasia. They can have, a complete global aphasia without being able to understand what's being spoken to them. These patients have much more difficulty rehabbing because they just don't understand language. They can have motor deficits on the right side, right paralysis, impaired discrimination between the right and left side. These patients may be very slow and cautious and very, very aware of the deficits that they have. They may be depressed or anxious, and they can have impaired comprehension related to language and or math. So your motor function is going to be your most obvious effect of stroke. Your facial droop, your arm drift, your weakness on one side. This can also include impairment of mobility, inability to breathe effectively. You can have paralysis of the diaphragm, which can cause problems with respiratory function. Your throat muscles can be paralyzed, which can impair swallowing and your ability to speak. Patients can have an impaired gag reflex, which also impairs their ability to swallow. And this is definitely going to impact a patient's self-care abilities. Characteristic motor deficits that occur in stroke can be akinesia, which is a loss of skilled voluntary movement. Patients can have impairment of integration of movements and alteration in muscle tone and reflexes. And the muscle tone and reflexes are pretty characteristic. Patients can initially be completely flaccid with their muscle tone, and then they can get spastic after a couple weeks as the muscle, as the tracts, what's the word I'm looking for? As the stroke progresses, they can be paralyzed initially and then they can be spastic. Same thing with the reflexes. You can have no reflexes initially after your stroke occurs, and then you can be hyperreflexive. And here we go. An initial period of flaccidity after stroke can last from days to several weeks, and it's related to the damaged nerves involved. After the muscles have that period of flaccidity, they can become very spastic because of the upper motor neuron interruptions. Physical therapy and occupational therapy are essential to rehab. And not only that, but they're going to see these patients as soon as they come into the hospital to assess their motor deficits and to help them to progress to their maximum level of functioning after having a stroke. Communication deficits, I think, are often some of the most difficult problems in a patient who's had a stroke. The patient who has a stroke on the dominant hemisphere of language, most often the left side, they can have aphasia. There are several different types of aphasia. There can be receptive aphasia, which means that I don't understand what people are saying to me. There can be expressive aphasia, which means I can't produce language. Like I may understand what's being said to me, but I can't get the correct words out to communicate. And there can be global aphasia, which is both of these things. I don't understand what's being said to me, and I can't get any words out. I can't express myself. Global aphasia. Speech therapy is essential in assessment and management of not only these cognitive and language deficits in stroke, but also of swallowing. And when you're talking about someone who comes to a stroke center for care, it is most definitely a team approach. There's going to be social workers involved. There will be speech, OT, and PT, and oftentimes you'll have the specialty, the neurology teams involved. There may be a neurointerventional team involved if there was some sort of clot retrieval done to the, for the patient. And it's just so important that a patient be at a stroke center where they can have the whole team involved. The outcomes are definitely better with a team approach. So these are just some different terms to describe speech difficulties in stroke. Dysphagia refers to impaired ability to communicate. It is used interchangeably with aphasia. There are different types of aphasia. Non-fluent means the patient has minimal speech ability. They have very slow speech. Fluent aphasia means a person can speak fine, but doesn't have any meaningful communication. Another term for this is word salad. So you might ask your patient how they're doing today, and they might say something, may I mumble dog face to the banana patch. It doesn't mean anything, but the words are clear and you can understand them. Many patients experience dysarthria, which is a disturbance in the muscular control of speech. So if they have a facial droop, they may have difficulty getting the words out because they can't move their lips. But you can understand what they're saying, and they can understand what you're saying. Impairments in muscular control of speech can involve pronunciation, articulation, and phonation. And so many things have to work well for a person to be able to communicate. A speech therapist is really invaluable when you're trying to help your stroke patients communicate. This is just another slide on how important speech therapy is to get involved when your patient has a stroke. Not only that, but the nurse, if your patient has a small stroke with minimal deficits, there may be a stroke swallow screen that's available to the nurse to determine if the patient can have a diet. This is only in certain places, and a lot is going to depend on how the patient, how the patient is. If a patient is unable to speak or understand speech, or both, and the terms for that are expressive aphasia, receptive aphasia, or global aphasia, working with a speech therapist will be an important part of their rehab plan. And different communication aids and strategies can be helpful. Depending on the location of the deficit, a patient may be able to use a picture board or even an iPad to communicate if they can't get the words out verbally. So you can look at this picture of this patient here. They have a pretty severe left-sided facial droop. And this is just an example of what a nurse swallow screen might look like in the hospital. So it asks, does the patient have a facial droop? And my answer, if I'm looking at this patient, would be yes. So I would not do any more screening on this patient. I would have to stop there. Then you kind of progress down the line. Do they have a gag reflex? You can evaluate their vocal quality. Are they gurgling? Are they coughing? If I ask this person to cough, can they produce a strong cough? And then you can try starting teaspoonfuls of puree and noticing if the patient has any coughing or choking afterwards. This is just an example of a nurse swallow screen. Of course, wherever you work, their specific protocols are going to dictate whether or not you could do something like this. It's going to be unit specific and facility specific. It is always the purview of the nurse caring for the patient to stop feeding the patient if you have concerns that the patient is choking, and ask speech therapy to see the patient again. They may have had worsening deficits and they may need to be reevaluated. People who suffer a stroke can have difficulty controlling their emotions. The emotional responses they have may be exaggerated or unpredictable. They can be magnified by depression, changes in body image, loss of function, and both memory and judgment may be impaired as a result of a stroke. Although impairments can occur with strokes affecting either side of the brain, some of the deficits you see are related to the hemisphere in which the stroke occurred. So again, going back to your left and right-sided strokes, your patient with a left-sided stroke may be more aware of their deficits and be more at risk for depression. Patients who have a stroke on the right side of the brain, they're more likely to have problems with spatial perceptual orientation. They can have an incorrect perception of themselves and their illness. They can have a unilateral neglect of the affected side. They can have visual changes, like this picture here is a patient with homonymous hemaniopsia, which I have to practice to say correctly. They can only see one half of each side of their visual field, so they cannot see the right side. This is why some patients have a severe neglect on one side of the brain, and you may have to go around to this patient's left side to actually have them regard you, because they won't be able to see you if you're on the right side. Patients can have agnosia, the inability to recognize objects, and they can suffer from apraxia, which is the inability to follow commands. So getting back to diagnostic studies, this is a picture of a plain head CT in a patient with a large completed stroke on the left side. These diagnostic studies are done to confirm that there is a stroke and identify the likely cause of the stroke, and also to guide treatment. A non-contrast head CT will determine between an ischemic and a hemorrhagic stroke. It will tell you the size and location of the lesion, and it's going to determine treatment. And because stroke therapy is so time sensitive, 99.99% of the time, the first study that you're going to be able to get will be a CT scan. It is much quicker to get a head CT than to get an MRI. So typically, you're going to see a non-contrast head CT done first thing when your stroke patient hits the hospital doors. After the head CT has been done, sometimes at the same time or sometimes soon after, a study called a CTA or an MRA might be done. This is a study that uses contrast to see the blood vessels. And you can look at these pictures here and see the little squiggly lines. That's the cerebral circulation. So you're looking at the blood vessels and you're actually determining which blood vessel is blocked, and these are also used to determine treatment. Cerebral angiography is done if the person is at a specialized stroke center and they have a neurointerventional radiologist who can actually take a tiny little camera and go up inside the blood vessels, and they shoot some contrast and take pictures to see those blood vessels. And they can use specialized stent retrieval devices to take out the blockage. Digital subtraction angiography is another imaging method. Echocardiogram is done to determine if they have a cardiac issue that caused the stroke. Lumbar puncture can be done, but these are specialized imaging that you wouldn't normally see unless you were in like a specialized neuro area. Lumbar puncture, a Lycox system measures oxygenation in the brain tissue, and other cardiac imaging can be done mostly to find out the source of the stroke so that we can prevent further strokes. But just know, plain head CT is most often first done, and then a vessel study, a CT angio. So TPA is like our number one treatment for stroke. It's an FDA-approved treatment for ischemic strokes. It's an IV medication which dissolves the clot and improves blood flow to the brain affected by the stroke. It must be administered, must be administered within 3 up to a maximum of 4.5 hours from symptom onset, and it may improve the chances of recovering from a CVA. It is a time-dependent intervention. I feel like a broken record. Time is brain. Make sure that when your patient comes in, you know when they were last seen normal. Trained physicians at stroke centers can remove a large blood clot in the cerebral circulation by using a stent retrieval device to the site of the blocked blood vessel in the brain. So basically, the patient has a CAT scan, they have a CTA done, and they see that there's a blockage in the left MCA. They can see there's a blockage there, and the physician takes them to the interventional radiology suite. They put a catheter in the groin, in one of the large arteries, and they put a small device, small suction catheter or a small stent retrieval device in through the groin, up through the heart, through the carotids, and to the area of blockage in the brain. And they can either suck that small clot out, or they can use a stent retrieval device to pull it out. This procedure is called a thrombectomy. It is very time limited. It's also done usually within 6 hours of symptom onset, and it's often done after TPA has been given. There was a study that came out, the Dawn study, which extended the time that people could have thrombectomies done based on signs of brain death on their CAT scan. So that's where it says C note, that's what it's talking about. This is just a picture of that clot retrieval device. Imagine this is your middle cerebral artery in the brain, and that kind of dark red area in the middle here is a clot, and this device just kind of wires through it, and you can pull it right out through that tiny catheter. Really revolutionized treatment of stroke. I've had patients come to me in my neuro ICU who've had large vessel occlusions, have been to the interventional suite, have had a thrombectomy, and have had complete restoration of blood flow and minimal deficits because of this therapy. So it's really important that if you have a patient who's had a stroke and you're at like a small community hospital, that you help be their advocate and get them transferred to a larger stroke center if they have the potential for this type of treatment. It really does change outcomes dramatically. This is a stent. We typically don't use a lot of stents in the cerebral circulation because the patient will have to be on like dual antiplatelet therapy for the rest of their life. But if you have very bad, atherosclerotic disease in the brain in a certain area, certainly you can put a stent in the brain the same way as you'd put a stent in someone's heart. Post-endovascular care, this is a picture of somebody's groin who had a thrombectomy and they had bleeding at the groin site. You can see all that bruising. It's important if you're taking care of these patients after they've gone to the procedure area that you check that groin site frequently. Make sure they are not bleeding. It's an arterial site, so you want to make sure that you assess frequently for complications. You're gonna, their blood pressure will have very specific parameters. You want to usually keep them less than 180, and you want to make sure that you assess for complications. They can have bleeding because it's an arterial puncture, and you want to make sure that that groin site is clean and you minimize complications. If certain criteria are met and a patient with a large completed stroke is in danger of death due to brain swelling, a neurosurgeon may offer a life-saving surgery called a craniectomy. In a craniectomy, the patient's skull is removed over the site of the injury so that the brain may swell and not cause the patient to die, herniate. So these patients may survive, but will almost certainly have significant deficits from their stroke. And age and size of stroke are criteria for surgery. And this is a rare occasion that this happens. It most often happens in a relatively young person who has a large completed stroke, because we know that that cranium is a kind of a small vault for the brain. There's not a lot of room in there on a good day. So if a patient is going to have a large amount of swelling, what may happen is the brain stem may be pushed down through the foramen magnum, and that will cause the patient to die. That's what we call herniation. It's a terrible complication of a large completed stroke. By offering a craniectomy, excuse my pup, by offering a craniectomy, it means the patient won't die. But when we say life-saving, that's what we mean. They will still have very significant deficits from the size of the stroke, and not everyone will be a candidate for this surgery. So how do you tell your patients to prevent strokes? It's the same broken record stuff that we say as nurses to our patient all the time. It's all those behaviors, right? Manage your modifiable risk factors. Eat a healthy diet, maintain a reasonable weight, participate in regular exercise, do not smoke, don't use drugs, limit your alcohol consumption, and stay up to date with your routine health assessments. For those patients who have pre-existing conditions like atrial fibrillation or a hypercoagulable state, you want to make sure these patients understand how to take their anticoagulants and to monitor effectiveness. This is, just the same teaching that we teach all of our patients. Maintain a healthy lifestyle. So just like in the previous slide, your patients who have atrial fibrillation, you want to make sure that they take their anticoagulation medicine as prescribed on schedule, and that they have frequent blood monitoring if they're on Coumadin to make sure that their INR is therapeutic. It's really important, as you'll learn about in your pharmacology course, anticoagulation is some of the most effective therapy for patients with atrial fibrillation to prevent stroke and other complications. For patients who've had a TIA or who have had a stroke, they will typically be on a full-strength aspirin, 325 milligrams daily. For your patients in the hospital, when they're taking aspirin once a day, remember that it is not being used for pain control, but as an antiplatelet drug. And therefore, these patients you're going to have to monitor for bruising or bleeding. They are going to have more difficulty clotting because their platelets will be inactivated because of the aspirin. Less frequently, you might see patients on Plavix or another antiplatelet, but most often it's going to be aspirin. So what about your patient who has a TIA and it's found out that they have carotid disease? They might be eligible for carotid endarterectomy, where they actually surgically remove the plaque from the carotid arteries. They might have stents placed, and they might have like an angioplasty, and much less frequently they might be eligible for a bypass. But that's a pretty invasive surgery that very rarely, I've only ever seen it once in my life in the ICU. So carotid endarterectomy, the surgeon goes in and opens up the carotid artery and removes the plaque and then sews it back up. Pretty common surgery and can prevent, stroke due to narrowing of the carotid arteries. So what about your patient that comes in acutely with a stroke? You're going to monitor the ABCs, make sure that they maintain their airway, make sure they're breathing well. You're going to monitor their blood pressure, and your goals for those patients are to preserve their life and prevent more disability. You're going to do a baseline neurologic assessment. You're going to make sure that you do a detailed neuro exam. You're going to monitor them closely. Oftentimes, our patients with stroke in the ICU have every 1 hour neurologic exams. Unfortunately, this can lead to delirium, because if you're waking someone up every hour and asking them the same orientation questions and, during a neurologic exam every hour, they're going to lose sleep, and it's going to be difficult for them to not get delirious. But it's important to monitor them because neurologic deficits can happen quickly, and their exam can change, and they might need some sort of intervention. So you're going to make sure that you do a good neurologic exam and that you stay up on those hourly neuros. Patients with a ischemic stroke or a hemorrhagic stroke may have elevated blood pressure. Very common, because the body's going to try and perfuse that area of damage. For patients with ischemic stroke, most often their systolic goal is going to be less than 180, and we call that permissive hypertension, to allow them to have a little bit higher blood pressure so they can perfuse their brain. You're going to work hard to control the fluid and electrolyte balance of your patient. Make sure you keep them hydrated, which can be challenging if they have swallow deficits because of their stroke. You're going to need to give them IV fluids and make sure that they have good amount of fluid on board to prevent any further injury. You're going to manage ICP using interventions that improve venous drainage, sit them up nice and high, make sure their head is midline on a pillow. And again, these patients that have had TPA for their strokes typically are going to come to a neuro ICU, and they'll get Q1 hour neuro monitoring, and it's definitely a specialized area. After the patient has stabilized, and to prevent further clot formations, most patients with strokes caused by thrombus and embolus will be given an antiplatelet. And most common, they'll have aspirin 325 milligrams daily. Patients who have atrial fib, as we talked about, will be anticoagulated to prevent stroke. And statins also have a proven benefit for these patients. They stabilize the plaques, and patients on statins have better outcomes in stroke. And one thing that's important to remember is that the patient who's had a completed stroke in the past is at a higher risk for having a second stroke. So Mr. PD is diagnosed with a thrombotic stroke. After the next 72 hours, you plan care with the knowledge that he A, is ready for aggressive rehab, B, will show gradual improvement of the initial neurologic deficits, C, may show signs of deteriorating neurologic function as his cerebral edema increases, and D, should not be turned or exercised to prevent extension of the thrombus and increase neurologic deficits. And the answer to the question is C, because over the next 72 hours, he's going to have swelling, and that will make his deficits, he may get worse before he gets better. So acute care for hemorrhagic stroke, we talked about before: manage airway, breathing, circulation, monitor their intracranial pressure. They're going to be getting Q1 hour neuro exams in the neuro ICU, and you're going to maintain the blood pressure goals, which are going to be a little different than the ischemic stroke patients in that their blood pressure is going to be a little bit lower. You want their systolics to be less than 160 typically. It used to be that they were maintained at less than 140, but then data came out that showed the outcomes were no different between 140 and 160. And sometimes these patients need a lot of different medications to get their blood pressure down. So we let them stay less than 160 for a bleed. Drug therapy for hemorrhagic stroke, obviously these patients are bleeding, so you're not going to give them anticoagulants, they're not going to get aspirin, they're contraindicated. For patients that come in on anticoagulation with a hemorrhagic stroke, they're going to need reversal of that anticoagulation, and that's not the area of this lecture, but know that there are reversal agents for many anticoagulant drugs, including Coumadin. For the nurse, the management of the patient's blood pressure is going to be the main focus, and you can use whatever agents the physician prescribes to maintain the blood pressure within a normal to high normal range with a goal systolic less than 160. Patients who have hemorrhagic stroke are at risk for seizures depending on the location of the bleed, and the neurology team will prescribe seizure prophylaxis on a case-by-case basis. For hemorrhagic stroke, it's less likely that they will have surgical therapy, but it may be offered. And again, this is not going to improve the patient's outcomes because of the stroke. It would only be to prevent them from dying as a result of the stroke. And for a hemorrhagic stroke, these patients have a very high mortality. 30 to 80% will die within the next 30 days. Again, this is a nice snapshot of what the nursing does for an acute stroke patient. You're going to make sure that they're safe, especially for those patients who are impulsive and unaware of their deficits. You're going to monitor their level of consciousness and their safety awareness. You're going to do your neurologic exams as ordered, probably every hour, if they're in an acute care ICU setting, and you're going to report any changes promptly to the provider. Maintain the blood pressure per the orders and report changes promptly. Treat as needed. Maintain their airway, assess their respiratory status, their cough reflex, any apnea, and remember that these patients are at risk for rapid decline. You're going to monitor them for dysphagia, assess their swallow reflex, assess for any nausea, difficulties with bowel sounds, or constipation. You're going to also monitor for urinary incontinence, any urinary urgency or frequency. We are really working hard to not have Foley catheters in patients because of the risk for infection. So oftentimes your stroke patients will have like either an external catheter on or the PureWick in the case of a female patient, and they may need to be straight catheterized if they have urinary retention. You're going to monitor their paralysis, any visual deficits or neglect of one side. You may need to, be careful with your positioning of these patients, and they're going to need frequent repositioning to prevent skin breakdown, especially if the patient is paralyzed on one side. Remember, they can't move themselves, so even if they feel that they're having, pain or breakdown on one side, they don't have the ability to move around. It's solely the nurse's responsibility. For respiratory system, you're going to remember that that will be a nursing priority for you. You're going to watch them closely for any signs of aspiration, any risk for airway obstruction. They may require to be intubated and be put on a ventilator for a little while. You're going to watch them closely for a decreased level of consciousness and sonorous respirations. And what I mean by sonorous respirations are like loud snoring respirations, like when a patient has difficulty being awakened and you're concerned that they can't maintain their airway. And you're going to notify the provider immediately if you're concerned about any neurologic exam change. Also, please take a minute to review the potential complications, collaborative problems of a stroke, and understand that you're not only watching their initial deficits. So say you have a patient that comes to you with a left MCA stroke, right? They have a right-sided paralysis. They are, emotional and depressed about their injury, and you're also worried about the potential for respiratory failure, the potential for aspiration pneumonia, the potential for seizures, the potential for decreased level of consciousness. These are all things that can happen with any stroke. It's a challenging patient to take care of because you can't really see what's going on inside their head. You have to do serial examinations and monitor for changes. So what are some nursing diagnoses that these patients can have? Risk for ineffective cerebral tissue perfusion or ineffective cerebral tissue perfusion if they have a stroke. You're going to make sure that you keep their airway clear. They can have ineffective airway clearance. Make sure they can cough and take a deep breath. They're at risk for aspiration. You're going to work closely with the speech therapist to make sure they're swallowing safely, that their diet is appropriate for what they can manage. They're going to have impaired physical mobility, and they can have impaired verbal communication, unilateral neglect, impaired urinary elimination, impaired swallowing, situational low self-esteem. And the emotional support of the nursing team is super important to these patients, not only the patients, but their families as well. So when you're planning for these patients, make sure that your goals not only include the patient themselves, but also the family, because a lot of these patients, if they don't go to a rehabilitation facility, are going to need a lot of family support to after their stroke. So some example goals are the patient will maintain stable or improved level of consciousness, attain maximum physical functioning, maximize self-care abilities and skills, maintain stable body functions, maximize their communication abilities, maintain adequate nutrition, avoid complications of a stroke, and maintain effective personal and family coping. And each one of these goals are very challenging, extremely challenging for patients post-stroke. Sometimes the rehabilitation from a stroke can take 1 to 2 years. And there are cases where the patient never regains, the functionality that they lost because of their stroke. So when you go to get PD out of bed and ready for therapy, he refuses to participate in transferring out of bed. Although he has seemed down throughout his hospital stay, he never refused to participate in the plan of care. What should you do? So as the nurse, you're going to be empathetic. You're going to take some time to listen to your patient. You're going to acknowledge how difficult and challenging this situation is. Yeah, this sucks. You had a stroke and you can't do things that you used to do, and I'm really sorry this is happening to you. Sometimes just acknowledging how challenging the situation is can offer your patient, the ability to grieve and the ability to, really just feel what's going on. Because I think in some cases, your patient may not be aware of their deficits, but when they are aware of their deficits, it's incredibly depressing for them. And it's important for you as a nurse to remain empathetic and to help them, come to terms with and cope with their new diagnosis. So, coping with a stroke it affects not only the patient but also the family. And I have seen so many cases where, patients, especially in their, 60s and 70s, if they're still working and they're still, the head of the household, and now they have a stroke and they're not going to be able to work anymore and they may not be able to return to their home. These are huge, massive adjustments. So, you're going to be dealing with not only your patient, but their entire family, because now, their wife may become their caregiver, or she may become the care coordinator and have to figure out, go visit different rehabs and figure out which one is best for their family member. It's going to affect the family emotionally, socially, it can affect them financially. They're going to have very different roles and responsibilities. And always remember that social work is available for you to help them adjust to this, massive shift. And you have a role in supporting coping as a nurse. Don't hesitate if the patient is, very depressed, and if you know that they're aware of their deficits and having, trouble emotionally, ask the provider to prescribe an antidepressant. I've often will prescribe an antidepressant for patients who have an acute stroke, just because it is such a massive role change and challenge that even a little bit of pharmacological support can make a difference. So there are many things available. Remember, as a nurse, you're the patient's lifeline to the provider. You're the patient's, advisor. You're going to be able to help the family come to terms and figure out what's the best, solution for everyone. Sometimes just having the families visit different rehabilitation facilities, and kind of figure out which one might be the best fit for their relative, can make a difference for them. So for patients with deficits, motor deficits, that's pretty much the oftentimes the most obvious deficit in a stroke. Your goal is to maintain optimal function of the patient's motor system. This is accomplished by the prevention of joint contractures and muscular atrophy. In the acute phase, range of motion exercises and positioning are very important. And paralyzed or weak side will need special attention when the patient's positioned. So it's important that you're aware of where your patient's deficits are, and that you use pillows or wedges or whatever your facility uses to position them so they are not dependent, so the patient isn't lying on them, so that they are supported well. And PT and OT are going to be involved with these patients, both in acute and long-term care. This is a good example of loss of postural stability. This woman has had a stroke on probably the right side, so you're looking at left-sided weakness. Actually, that left arm looks like it's got a little bit of a contracture now. This is probably well beyond the acute phase of her stroke, and she's leaning to that left side because she's lost the ability to use the muscles on her left side to sit her midline. So as the nurse, you would see this patient and you would say, "Oh, let me reposition you," and you would put a pillow beneath that left side arm. Another thing that I would worry about with this patient is the arm rail. You can kind of see that her arm is like underneath the rail of the chair, and I would worry that she's not able to move that arm out of the way and she could have skin breakdown where it connects with the chair. So many opportunities for repositioning. Make sure your patient is safe. In acute care, you want to make sure that you are caring for your patient with immobility, because they are going to be at risk for venous thromboembolism, also known as a DVT. Especially if they have immobility or any loss of tone, they're not going to be able to move their legs. We tell our patients while they're laying in bed, do your ankle exercises, pump your feet up and down so that you keep those calves moving even while you're not mobile. Now, your stroke patients aren't going to have that ability, so you want to keep them moving if you can. You're going to apply the intermittent pressure devices and make sure that they are on and functioning. And in my ICU, everyone has thigh-high SCDs, sequential compression devices, that are on and functional all the time. In addition, your patient should always have chemical DVT prophylaxis ordered, heparin or Lovenox subcutaneous, unless there's like some acute contraindication like a big bleed or the surgeon is, concerned about it. But really, all your patients should have chemical DVT ordered, and do not hold it. You want to make sure you prevent any skin breakdown. We talked about this a little bit in the last couple slides. Make sure you're changing their position frequently, that you're using the low air, air loss mattresses in the beds. Make sure that they have appropriate cushions for their wheelchairs. If you have to turn them on their weak or paralyzed side, minimize the time that they're on that side. And make sure that they are clean and you use whatever lotions or products you have available to protect their skin. Early mobility is one of the best ways to prevent atrophy or complications of immobility if your patient can tolerate it. PT usually will be getting our patients up the next day as long as they, have strength in their legs and they're able to do that. Of course, the risk of immobility increases with patient age and poor nutrition, motor or sensory deficits, dehydration, swelling or edema, and incontinence. So what are your priority nursing interventions for PD? You want to make sure that you protect, keep him safe with his stroke. Make sure that you position him carefully with his weak side up or positioned so there's no risk for injury. You want to support him emotionally. Make sure that if he needs it, he gets an antidepressant and that social work is involved and that he is an active participant in his care plan. You're going to make sure he gets good nutrition. If he can, if he's past his swallow eval, make sure he's tolerating his diet and getting enough nutrition to heal with. If not, the family, your provider will have a conversation with the family about whether or not he might need a feeding tube. There are so many systems affected by stroke. Really, you are going to be looking at these patients individually on a case-by-case basis. What teaching are you going to need to do for him and his family? He likely will still have atrial fibrillation after he leaves the hospital, and you're going to make sure that they understand the need for him to take his anticoagulation medicine as prescribed and monitor his INR appropriately to prevent further strokes. You're going to make sure that they understand what PT's plan is for his weakness, what kind of exercises he will get, whether he'll get, home services or whether he's going to a rehab facility. You're going to make sure that you're coordinating and making sure the family's aware of the care for this patient. And we don't know what the plan is. I'm assuming he'll probably go to a rehab facility where PT and OT and speech will be available to work with him on a consistent basis. The goals for your patients are going to be developed collaboratively with the patient, the caregiver, and the family. And these goals will include that the patient will maintain a stable or improved level of consciousness, attain maximum physical functioning, and maximize their self-care abilities and skills. Usually they're discharged from acute care to either home if they're able to get up and care for, do their ADLs with minimal support, an intermediate or long-term care facility depending on their deficits and their ability to do things for themselves, or a rehabilitation facility. Now, the difference between going to a long-term care facility versus a rehab facility is going to be their ability to participate in ADLs and participate in, I think it's 3 hours of rehab per day. Ongoing rehabilitation is very important to maximize the patient's abilities. Again, with my stroke families, I usually tell them that this is a marathon and not a sprint. Don't expect your loved one to be back functioning at 100% within a couple weeks. Oftentimes, rehabilitation from a stroke can take a year or more, and some patients will never regain deficits that have been lost. So it's important that the family is realistic, but also has hope as far as rehab. Rehab is the process of maximizing the patient's capabilities and resources to promote optimal functioning. It's important for the patient to participate, and it improves their physical, mental, and social well-being. And goals are all set mutually by the patient, the family, the nurse, and the stroke or rehab team. And here we have a picture of someone relearning walking after what we can assume is a stroke. So, for musculoskeletal function, if the muscles are still flaccid several weeks after the stroke, prognosis for regaining function is poor, and the focus of the care should be on preventing additional loss. Many patients begin to show signs of spasticity with exaggerated reflexes within 48 hours following the stroke. So, an initial period of flaccidity followed by a period of spasticity. And really, if they haven't regained any function after a few weeks, it's highly unlikely that they're going to regain function in that areas. Here we see some pictures of different assistive devices for eating. So for patients with fine motor deficits, the larger utensils that you see in A and B and the kind of adjusted knife are nice for patients who can't, manipulate their fork and knife like they did pre-injury. In C, we see some plates that have a lip added to them so that patients can kind of scoop their food to the lip instead of having to manipulate it to get it on the spoon. And then D is just a picture of a handled cup, which may be easier for someone with a stroke to manipulate. So for ambulatory and home care, we didn't really talk a lot about bladder or bowel interventions. Initially post-stroke, patients may have some urinary retention, but often for a patient who has a stroke on one side of their brain, the opportunity for bowel and bladder function is very good. Sometimes you can implement like a bowel training program or a bowel management program for patients who have like constipation or incontinence, and this can consist of like stool softener like the picture, or make sure they have a high fiber diet and adequate fluid intake. For patients who have emotional, atypical emotional responses, like if they have outbursts or if they, start laughing for, unusual reasons, they can have many different atypical emotional responses. As a nurse caring for these patients, you're going to distract the patient and make sure that you explain to the patient and the family that sometimes atypical emotional responses or outbursts can occur. You're going to maintain a calm environment and avoid any sort of shaming or scolding the patient. It's very important that as nurses that we don't infantilize our patients, that we treat them as adults, as humans, and just maintain an environment of understanding, but also of encouragement. You want to lift your patients up and make sure that even if they respond in an unusual manner, that we still treat them with respect and dignity. So home and community resources, and of course I'm speaking from a pre-COVID perspective, and hopefully we'll get back there after the pandemic is resolved. I'm speaking as an eternal optimist. Not only home care, but also community care, like daycare for adults or stroke rehabilitation, can be valuable assets to patients and families after patients have had a stroke. Your nurse case managers and your home health nurses, clinical nurse specialists, and discharge planners, as well as social workers while you're still in the hospital, can all identify and contact resources. And there is national and local help available. And I would start with the American Stroke Association because they are a well-known national resource. So specifically when talking about the elderly, stroke is a significant cause of death and disability. 66% of the strokes that require hospitalization occur in adults greater than 65. Age is really one of the primary risk factors for stroke. Both the patient, the caregiver, and the family require ongoing assessment and adaptation to changing needs. Frequently, I'll see elderly patients who have been completely independent, living at home, and we're talking the oldest 87, 90-year-old people who, now that they've had a stroke, they won't be able to return to their home and their independence. So really, for this age bracket, a stroke often is a life changing and sometimes can be a life-ending event. So it's important that you have conversations with your family members to make sure that you are meeting the needs of your patients in the way that they would want them met. I have linked this TED Talk to this lecture because this is a super powerful 20-minute TED Talk about the experience of a patient having a stroke, and not only any patient, but Jill Bolte Taylor, who was like a brain anatomist, like she studied the brain for her work, and her description of what she felt when she was experiencing a hemorrhagic stroke is phenomenal. So I really encourage you, I strongly, strongly encourage you, if you've not had the 20 minutes to watch this, please do, because it will change the way you view and care for your stroke patients. And really, that's what it's all about, is just being there for your patients, making sure that you're monitoring them closely, doing serial neurologic exams, and treating them the way that you would want to be treated, or your family member would want to be treated if they had a stroke. So I thank you for your attention. Again, thank you. This is just a nice little photo I put in here because it just kind of illustrates the difference between the left and the right brain. And, just to sum up, stroke affects the area of the brain in which it occurs. And you want to make sure that you're caring for your patients individually, because each patient who has a stroke is going to have a different presentation and a different response. So it's a challenge as a nurse to be a good stroke nurse, but it's really makes a huge difference in your patients' lives. So thank you.